Hello, welcome to part 3 of the seminar on neonatal abstinence syndrome. My name is Sabrina Quigley. I am a social worker and case manager in the Eskenazi Hospital Newborn Intensive Care Unit. I have been at Eskenazi, formerly known as Wishard, for 26 years and in the NICU for the last 18 years, and I'm very happy to be here talking with you today about neonatal abstinence. It's a topic very near and dear to my heart, so thanks for joining us today. I've got several objectives I'd like to complete with you today. One is understanding the family perspective of neonatal abstinence syndrome, helping to facilitate a team approach to NAS in both the OB and the NICU settings, develop a safety plan for an infant and treatment plan for the family. There's also a special circumstance I'd like to spend a little extra time on, is that of adoption. We frequently have babies who are being adopted by parents who don't have any experience or knowledge of addictions or NAS, and so I just wanted to review a few extra terms with them. How to coordinate with outside agencies to help attain a safety plan for the infant and a treatment plan for the family. And lastly, how to facilitate a discharge plan and outpatient follow-up. For the purpose of this presentation, we will presume that a full psychosocial assessment has already been completed by the social worker. So I'm not going to talk about how to do that assessment, but more to make sure that we understand what needs to go into that initial assessment with the family. As soon as the baby's admitted to the NICU for the NAS, I believe that a social worker should see them and review the basics like their current living situation. We want to know who is all in the household, who are the support systems, who may be perhaps causing some barriers to this family as well. I do a full assessment of the drug use history of the mother and the father, if he is also involved or living in the home or having a history of addiction himself. I'd like to know what their current treatment plan is and what the planned treatment needs are of the parents. What are the unmet needs of the family? And then what are the family's needs going to be during the baby's hospitalization? Sometimes that involves things like housing, supplies, finances, transportation, childcare for visits, and rooming in at the end of the stay. So these are all things that I won't discuss today further. I think that's a part of a basic psychosocial assessment that should be done for every parent who's got a baby in the NICU. Okay, so starting with understanding the family's perspective, the first delineation that I'd like to make known here is I think it makes a big difference as to whether the drug use was for prescribed medications or non-prescribed, and that adds a lot to how both the family and other caregivers for the baby will view this baby's neonatal abstinence syndrome or NAS. If the mom is on prescribed painkillers only, for instance, we've recently had a baby admitted to the NICU for NAS whose mother was just on chronic painkillers for a sickle cell disease, and she had frequent exacerbations during her pregnancy, and so she was on scheduled or opiates for that. So we knew the baby would go through the withdrawal. Her family was aware the baby would go through withdrawal, and they were all pretty accepting of that because this was what they considered a prescribed necessary regimen for her health. Also, we have the moms who are on Suboxone and Methadone, and that's the only thing they're taking. So again, that is something that they have started treatment for their history of addiction, and they're currently clean from all other substances and doing well in their Methadone or Suboxone program. Those babies will also get admitted to the NICU for withdrawal, and I feel like they and their family have a little bit, a lot more actually, shall I say, acceptance of what's going on and feel okay with it for the most part because they know that they have been treated under a physician's care and are doing things what they might be called the right way. On the other hand, you may have those who are using methadone and Suboxone, but also using other drugs, say heroin, Norco, Percocet, Dilaudid, whatever their opiate is of choice, or it could be other things including methamphetamine, cocaine, marijuana, alcohol. Benzos is a big one, like Xanax or Valium to help them get through the anxiety phases. So if they've got those other drugs, which we could call street drugs, if they come without a prescription, so I'm not going to differentiate between the heroin and the non-prescribed Xanax in that case. Those I'm going to refer to as a street drug because they weren't prescribed to that individual for a medical condition of their own. So looking at all of that, if you've got the prescribed versus the non-prescribed, is going to factor into how people feel about that mother and about what the baby is going through, including their own feelings about what they're going through for the mother. So some of the maternal feelings we need to be sure to address are guilt, helplessness, anger. Even for the moms who are on only a prescribed regimen of narcotics or methadone or Suboxone, have a true heartbreak when they see their babies going through withdrawal. The baby's crying and fussy, won't latch if they're trying to breastfeed, they can't coordinate a bottle feed, or they're just very, very jittery, inconsolable, and the moms sometimes just sit and cry. They're just heartbroken that their baby has to go through this. Even though they may have known it was going to happen, it's really, really hard on them. The helplessness, they just don't know how to make it better. They feel like, I did this to my baby, but I had to because this is what I needed to do to stay healthy for my baby. And they can also be angry. There's a lot of anger about the treatment, the morphine, the baby needing to be in the hospital a lot of times. Or sometimes it's self-anger for the mother who's been using, say, heroin or other drugs in addition to their prescribed methadone or instead of methadone or Suboxone or anything like that. The dad's feelings, usually the dad knows that the mom is on whatever she's on. Sometimes he doesn't. That does, I will say, make a very difficult situation in the NICU if the father of the baby is involved and he's visiting and the mom hasn't told him that she's on methadone or on heroin or on whatever is causing the baby to be there for withdrawal. I have some pretty in-depth private conversations with this mom onto why the father of the baby needs to be aware of what's going on. It puts us in a very awkward situation in the NICU, and by us I mean the physicians, the nurses, myself, anybody who's participating in that baby's care have a hard time deciding how to best help the mother and the baby if the dad doesn't know what's going on. So I will usually say, it's bound to slip at some point that this baby is on a medication. So please help us by, just being upfront with him and letting him know what's going on. Typically the dad knows. In those situations, though, when he doesn't, we do strongly encourage that. And I frequently will just offer to sit with the mom while she tells him, or once she said, you tell him, but I'll sit here. And so I did. And, we do what we have to do to try to help him understand what was going on. Extended family, what is their level of understanding? That's also important to know, especially if we have visitors coming a lot. We may have grandparents or a sister or a cousin or whoever the primary support people are for the family. If they're coming in to see the baby and they don't know what's going on, that also does make it really difficult. And so especially if they're frequent visitors, we've had families who say, the grandma's going to be here all day while we're at work. But if she doesn't know why the baby's there, it makes it very difficult. So again, the best thing is to encourage the family to be upfront, the parents to be upfront with their relatives, and at least those who are going to be a primary support person for them during the NICU stay. Please let them know what's going on so that they can best help you, and they can best know what they're facing when we ask for their assistance in comforting the baby and trying to help him feed and things like that. So it's very helpful if the support people coming know what's going on. A lot of times we've had families try to hide it in terms of, they'll say the baby's not eating yet, which frequently the baby is not eating due to discoordination with feeds, that they can't quite get that together because of the withdrawal symptoms. So although part of that is true that the baby is having difficulty feeding, and yes, that involves why the baby's there, the withdrawal part isn't addressed. And for those situations, again, when there is a relative who's going to be there very regularly, we do ask the family to at least strongly consider telling them exactly what's going on. In addition to being able to best help the baby, then they can better help the family. I figure if they're relying on their family member to be there and comforting their baby, holding their baby, participating in his care, that same person would be a wonderful support for the mom and for the dad if they know what's going on. Although a lot of times there's anger or shock when they first find out, they're there really because of their love for the baby and the baby's parents. And so we like to rely on as much support for the parents as we can get. That's really important, especially for the moms who are not using just prescribed medication. If they have an addiction to non-controlled substances, they need extra help. This is nothing that you can do on your own. We don't live in a bubble, and this baby is not living in a bubble, and the baby's got his parents and family members around him. We like to try to assess what is going to be the level of involvement or assistance that this family member can provide. And I will say family, and sometimes it's not blood family. Sometimes it's a cousin, or a friend, somebody from the church, a neighbor. Really family is whoever is going to be the best support for that individual. Women with drug addiction have sometimes burnt bridges with their own family members, and they might not have the support of them around, but they may have somebody else that they have found to be helpful for them in their recovery, and that's what's very important. Next, I want to talk a little bit about the team approach for both the OB and NICU team. Prenatally, starting there, I'd like to stress the importance of prenatal drug testing. I really feel that every woman who comes into OB care should have at least a screening, urine drug screen, when they have their very first OB registration appointment. If that test is positive for anything that's either illegal or not prescribed, this should be followed with a urine drug screen frequently throughout the pregnancy. My goal would be at least every month. And for the women who are on methadone or Suboxone, I believe that they should also have a urine drug screen. Monthly would be great, or at least each trimester when they come in. And with that, I think it's really important for their provider to talk with her about her use and her treatment plans and what's going on with her and why is she testing positive for these particular things. Is there anything the provider can do to help them? Does she have the resources she needs? Is she interested in treatment? That kind of thing. All are very, very important. And there's really the best opportunity comes from the OB provider themselves, either the nurse in that OB doctor's office and or obviously the physician would be great. I have an awful lot of women who come in and say, well, my doctor knew I was using, but they never said this. Again, you never know how much they don't want to hear, and how much they don't hear, and how much might just be a provider's reluctance to bring up issues that are uncomfortable. And I do find that a lot, especially in a teaching facility when we have newer interns and residents who aren't used to maybe discussing these issues with women, and they're a little afraid of hurting their feelings or sounding judgmental, or they just don't know how to bring up the subject. But honestly, you are doing a huge, huge favor to this woman if you will, as an OB provider, please bring up the fact that yes, she tested positive for whatever that substance was. And if they can just have a conversation with her. Why are you using this? And what else is going on in your life that is causing you to do this? And, select this choice, and how else can we help you? And if she's testing positive for, say, Norco or Lortab or codeine or heroin, and the doctor can at that point say, hey, let's talk about getting you on methadone if we can. That's obviously the safest. I know there's more of a risk of miscarriage with Suboxone, although a lot of people will use that as well. And so that's just, again, a decision for the OB provider to have with the woman. What else can we get you on to help you safely and your baby get safely through this pregnancy with the best outcome for your baby? The other thing it would be really helpful to have is a talk with the woman ahead of time. If she's testing positive for illegal or non-prescribed drugs, if the OB at the time or the social worker in the OB's office or the nurse or somebody says to her, I want you to know that your baby's going to go to the NICU for withdrawal at the time of delivery, and like kind of what that looks like. At Eskenazi, any mom who is on methadone, the baby goes to the NICU automatically for 5 days, a minimum of 5 days. And then we follow the modified Finnegan scoring system. And if the baby gets started on morphine, then we just say kind of all bets are off. At that point, it's totally up to the baby how long they're there and how long it takes the baby to wean. But we do like them to know that it will be a minimum of 5 days for any mom on methadone. If they're on Suboxone or on other prescribed painkillers, Norco or something, we will let them know ahead of time that the baby's going to be in the hospital, again, for 5 days. For those babies, they can stay out with the mom and get the scoring done out there. But if the scores lead the baby to requiring morphine, then the babies are moved to the NICU for completion of their course. So for the moms to know that ahead of time, although they may be angry or scared, at least by the time they get to have the baby, they're not surprised. And at that point, it becomes a really big issue if they're like, my doctor never told me my baby'd have to go to the NICU. Why can't the baby be with me? And they get really upset. So if they know ahead of time at least what to expect, that would be extremely helpful. When they come in for delivery, please get drug testing. If you are a provider, if you can, or a nurse in the clinic where they show up, please ask for them to get a drug screen prior to their receiving any pain medications in the hospital. We will frequently get a mom or a baby with a positive morphine screen, and we don't know whether that's from the morphine she got or whether it's from something she took before she came into the hospital. So if that can just be routine, if you were going to get a drug screen on a mom and maybe just a quick run through of their history, if they've got any history of drug use, prescribed or otherwise, during the pregnancy, please do run a screen. And then after delivery, we need to make sure that the baby is tested, a urine drug screen at least, and then either a meconium drug screen or a cord drug screen for the baby. So the interdisciplinary approach, this is where I think it's really important to realize how many people are actually involved in the care of this child and the child's mother. I love having an interdisciplinary team available. We've got nurses and nurse practitioners and physicians, neonatologists. We have medical students, nursing students, and then this huge network of other team members that we rely on. Our lactation consultants, people in our OT department. We have a fabulous OT and speech therapist who work with our babies in the NICU. Some NICUs have child life specialists, some have physical therapists. However that works is great. Nutrition is a big part of a baby's growth and development during that NICU stay, and our nutritionists are wonderful, having their input on and tracking the baby's growth, how they're doing, do we need more calories? Babies going through withdrawal are frequently using up a lot more calories than they're taking in, so frequently they need to be on higher calories. And so involving all of those people is very helpful. Pharmacy obviously might be able to help with the morphine dosing, as well as seeing if a second medication needs to be added. A lot of times when we have a second drug class, like if we are having a baby whose mother has been using benzodiazepines as well as narcotics, frequently we'll have to add phenobarbital to that regimen of treatment in our NICU. That's important. So, and of course, my own special favorite involving the social worker is integral part of this. Of course, I say that because that's me. And I'm also the case manager, and I do all the discharge planning. So if those roles are separated out in your NICU, then please involve all of them, because the social worker, the case manager, and the discharge planner will all have also a piece with this interdisciplinary team. One of the things that I would also like to address right now is the real-time, one-on-one approach with the moms. This is a huge opportunity, especially for nurses and our lactation consultants as well, because they spend a lot of time just one-on-one with the moms, and especially the bedside nurse for the baby in the NICU. They will spend many, many hours and get to know these moms really well. And a lot of times moms will open up to them about things they're not going to open up to me about or their doctor about, and they'll just start talking. And I love NICU nurses. They are amazing. We have the best group of NICU nurses at Eskenazi, and they just are caring and compassionate. They treat the babies as they would treat their own. They're loving with them. But they're also very supportive to these moms and dads that are having to watch their babies go through the withdrawal. And so a lot of times these moms will just open up to the nurses, and it's huge. You know, if they say something to you, you're not sure what to say, how to respond back, just say, I don't know what to say to you right now, but I'm so happy you shared with me, because that in itself is just an honest, open answer. And that's what they need. Women facing addiction are in a really tough spot. They feel frequently judged by others in the community and feel like the people in the hospital are blaming them for their baby's condition and looking down on them and judging them. And honestly, we can make such a huge difference with them if we show acceptance and say, you know, you may have your issues and this may be a choice that you've made before. Doesn't mean it has to be the choice you make next time. And I need them to know from everyone that it's okay to be human. It's okay to have made some mistakes, but what do we do next? What's the next step going forward? I think that's a really big piece to try to work on with these moms and the dads. Developing a safety plan for infants and treatment of family. I think before I go here, I'm going to step off of the slides for just a minute and discuss the father's treatment issues as well. I think sometimes the moms and dads are both using, and the dads will have their own addiction issues that are never really addressed because it's just the mom's issue that brings the baby into the NICU for treatment of NAS. And so I think it's very helpful to know, are mom and dad using together? Is she trying to be clean and he's still using? Or is he clean and he's trying to help her, but she's still using? And so there's a lot of times those relationship issues are coming up. And it's really important to assess those issues because, one, having a baby in the NICU is really stressful on relationships anyway. It can be. It's not always, but I frequently find that the moms want to be there a lot. The dads are like, why are you always at the hospital? What about our other kids? What about me? What about our home? Or, you know, it might be the other way. Mom feels too guilty to be there often, and so dad gets angry with her. Why don't you be at the hospital more? Your baby's going through this. You caused this. You know, there's lots of different kinds of things that come up here. Terms of relationships between the mother and the father. And so making sure that we've done a full assessment on what the dad's needs are as well as what the mom's needs are is very important, and can really go a long way in terms of trying to help them with their own treatment plans. So on to developing a safety plan for infant and treatment for the family comes the the hard topic, DCS. People want to know, when is Child Protective Services coming? Are you going to take my baby? Why are you doing this to me? That kind of thing. So first, it's important to know when DCS is involved and when they're not. Each hospital has their own policy, so obviously follow your hospital's policy on that. At Eskenazi, I can only speak to that because that's the only hospital I've ever worked at. But if the baby tests positive for anything not prescribed or illegal, we must file a report with Child Protective Services, whether that's marijuana or heroin or alcohol. Well, alcohol is a hard one to test. Forget I said that. But benzodiazepines, things like that. It's all anything that's not prescribed, we do have to report. That comes down to the part that's hard to tell. Again, if they test positive for the morphine and they got morphine in delivery, but the mom is admitted to using heroin, then you're like, okay, is this morphine a metabolite of her heroin, or was this from what we gave them? Which is, again, why I stress the importance of please getting a drug screen before we give medication there. When we used to do meconium drug screens, which some of the hospitals are still doing, it's again hard to know then if the baby got started on morphine for NAS prior to having the meconium collected. Then again, when we get a positive meconium for morphine, it's hard to know, was that what we gave the baby, or was that from something the mom took during the pregnancy? So if you are a hospital still collecting meconium drug screens, then do try to get the meconium before starting morphine when possible. Even if it's a small sample, try to send what you can initially. In terms of relapse prevention and treatment for mom, I'm sorry, I moved on before I was done with the last subject. I apologize. Let's go back to involving DCS. If they are then positive for a screen, I just tell the moms that. If you or the baby, well, if the baby is positive, we have to file a report. If the mom is positive for an illegal or non-prescribed drug at the time of delivery, I will also file a report. Sometimes we don't get a good screen on the baby, like especially the urine. If it's not the first void, it may be negative. And so if the mom tests positive for, especially if it's like heroin or cocaine or something like that at delivery, even if the baby has a negative screen, I will file a report with Child Protective Services, or even if it's been within the last couple of weeks prior to delivery, because that means they still have an addiction that is still very recent, and we just want to ensure safety then for the child when the child goes home. When not to, if the mom and the baby are testing only positive for methadone or Suboxone or say Percocet, as long as whatever they're testing positive for was prescribed by their physician during the pregnancy, then we don't involve Child Protective Services. So again, sometimes it ends up being a judgment call in terms of other things just don't quite feel right. Yes, they only tested positive for the morphine. Mom did get morphine, but the other things. She doesn't have custody of her other kids, or she is homeless or has moved like 10 times during the pregnancy. Or just doesn't seem to have a lot of resources, then in those situations involving DCS is also warranted. My main thing that I tell people, though, is I'm very honest with them when I very first involve DCS. And I'll tell them I'm making the report and this is why. And I always let them know this is not a punishment, that Department of Child Services frequently has resources for families that I could not otherwise access for them, and including treatment. Sometimes DCS can help the mother and or the father get into treatment where they might not have other insurance coverage to help them with it, or they might have issues with childcare or transportation or something, and sometimes DCS has access to additional resources. So that's also very important to know. Talking about relapse prevention and a treatment plan for mom, and I'll say, and dad also if needed, this is a huge part of treating the family whose baby is going through withdrawal. One of the main things I worry about is moms who try to wean off their methadone too fast. So, talking about relapse prevention and how we're going to keep mom clean, especially those moms who have managed to stay clean throughout their pregnancy, but now are going to be getting off of their methadone quickly. How do we keep them clean so that they can best take care of their baby and themselves? I think it's really important to address any underlying mental health issues. Frequently, women have started using drugs as a way of self-medicating. They have a history of depression, anxiety, maybe post-traumatic stress or bipolar disorder, but they've got a lot of other things going on in their mental health issues that haven't been properly, if ever, addressed. And so that's frequently when I talk with moms who have addictions, whether it's to alcohol or street drugs or even just like benzos they're getting from friends or whatever, it's because they don't want to feel the way they're feeling. They're sad, they're nervous, they're anxious, they've got the social anxiety, or they just don't want to feel the way they do. So they start using any kind of mind-altering substance, and that helps them to not have to feel that pain that they're going through. When you actually get to talking with a woman with an addiction, you will find for many a really rough past. Maybe they grew up in foster care, maybe they were sexually abused, maybe they've had domestic violence relationships with loved ones. They saw their own family in a cycle of addiction, and that's just what they've known. I've had an awful lot of women tell me that, they got their first cocaine or heroin from their mom or their dad, or that's just kind of what they did. At holidays, they would, all smoke pot together or whatever. So it's an issue that really needs to be kind of delved into why are you using and why did you start? Why are you continuing? And do you want to change? Some are not ready for a change. And I've had women say, actually very recently, I had a woman say she was not ready to stop using drugs, but she was ready to finally get treatment for her depression. And for her, that was a huge start. This was our third baby we had had together in the NICU, all for withdrawal. The first one went immediately to foster care when he was born. After his NICU stay for NAS, they had both tested positive for cocaine and heroin, and he was removed and went to foster care. The second child, when she came in, she had been incarcerated and was living at a residential halfway house and doing pretty well, actually, with her program. And she had stayed clean during the pregnancy, other than her prescribed methadone, and she got to take the baby back there to that facility. And she said she relapsed about 4 months later and then lost custody of that child. So this last baby she had, she was still actively using, and in addition to her heroin, she was using methamphetamine, which she and the baby both tested positive for. And she placed that baby for adoption. She said she just could not do the DCS again. She couldn't keep trying and failing and having her baby go from different foster home to relative placements and bouncing around. And she said it was just way too hard on the child. And so I was much admiration for her and her strength. And she said, I feel like I'm taking the easy way out because I don't want to deal with DCS. And I'm like, no, that was so not easy. This is the hardest decision you've probably ever made in your life. And to know that where your limits are right now and where you feel you can or can't do for your baby, you're instead providing a really safe and wonderful family for this child. And so trying to help her understand, maybe step above her really low self-esteem that she had in seeing her and acknowledging her strengths and what a wonderful decision she was making for this baby. And understanding too that in the course of her addiction right now, she was in a place that she said she's just not ready to stop. But she was very much more open about her depression and how sad she is now currently and what she's going through. And but she wants help for that. So we got her to counseling, and I think she's actually going to follow through with that. And maybe later she'll be ready to tackle the addictions too. But at least getting those underlying mental health issues addressed first can only help her in her later struggles with fighting the addiction as well. Sometimes medication can be really helpful for these women, anti-anxiety or anti-depression meds. Counseling is huge. And so again, dealing with not only the addictions counseling or the addiction medication, say methadone or something, but also antidepressants and helping them get to the root of the problem so that they can better tackle their addiction next. So I talked a little bit about the adoption. So one would be working with the birth mom. So like in this situation I was just telling you about the last mom, getting her into counseling was a big step for her. Obviously, because she and the baby both also tested positive for methamphetamine, we did have to involve Child Protective Services, Department of Child Services, sorry, with a report. Now, in this case, the baby tested positive, so we did have to make the report. As to what DCS will do with it at that point is just up to the DCS caseworker and supervisor. She doesn't have any other children in her custody or care, and she made a safe plan for the newborn. So they may or may not require any additional services for her or interventions, but I always let the birth mom know that I do have to make this report regardless. Sometimes with an adoption, the birth mother will still have custody of her other children, although she's made an adoption plan for the newborn, or their other children may be in foster care that she is trying to get back. So I always am real honest with them and say, I do have to make a report to Child Protective Services. They may or may not be calling you. It may or may not affect your other case, but I need to let them know. And typically, if they do have an open case with DCS and we're filing a report because her newborn is testing positive for drugs, even if she's making an adoption plan, that will indeed affect her other case. That the caseworker will know she's still currently using, but at least it won't involve this child becoming a ward of the court. I also want to let the adoptive parents and the adoption agency or attorney that they're working with know that I'm making this report to Department of Child Services and that it is based on the birth mother's use, not on anything that they have done. So to try to keep that separate, I include in my report only the first names of the adoptive parents, and then I give the adoption agency or attorney's name and phone number for the contact, so that if the DCS caseworker wants to talk to the adoptive parents, they will need to go through the attorney or agency, so that I'm not sharing their confidential information with DCS. We also want to make sure that they realize that the report is not, again, against them. Adoptive parents have the real fear that, yes, that they will all of a sudden show up on some DCS report for their state, or that will affect their adoption or future adoptions, future fosterings or something like that. Or they may be in a profession like law enforcement or social services or nursing where a mark from DCS would hamper their career. So again, it's real important that they understand that the DCS is only for the birth parent. Working with adoptive parents, though, we need to make sure and spend a lot of time with them in education and support. They're frequently also very upset and sad to see the baby going through the withdrawal, and it's very normal for them to feel a lot of anger towards the birth mother when they see their child going through this withdrawal. They're like, how could she do this? How could she treat an innocent baby like this? How could she do this during the pregnancy? And there is frequently a lot of anger involved. And it's okay to let them vent, get that out. That's all right. Because they do have a lot of mixed emotions about it. They're angry at the mother, but at the same point, they're so grateful for the gift they've been given by the same birth mother. So for a lot of them, there's a lot of conflict of emotions going on, and it's really important that they receive our support. And like I said, sometimes it's just an ear to listen, but also helping them understand the addiction, that it's not choice for the birth mom. And the birth mom also needs to hear this, whether it's the birth mom placing a baby for adoption or a birth mother parenting their child, that the addiction is not something they chose. Nobody as a child in school says, I want to grow up and be a drug addict. I mean, nobody ever does that. And if they could just stop because they wanted to, they would. Addiction will take over your whole life. It's so many, the moms that I work with say, I've lost my other kids, I've lost jobs, I've lost, contact with my parent, or I've lost friends, lost apartments. They've lost a lot, and they continue to use. And so many people don't understand, how can you continue to use when you've lost so much? And that's why it's really important for that counseling and mental health to go hand in hand with addictions counseling, because it's not a cycle that can just stop by sheer willpower. You can't just stop using drugs because you want to and you know it's best. And when I'm working with a mom who says, well, now that I've got the baby, I'll stop. I'll be clean now. But it's just not that easy. And in that little honeymoon phase, within the first few days after the baby's born, they're like, I don't even want to use anymore. I can do this. But I worry about them for the long term. And so I'm honest with them about my worries about that for the long term. I'm like, I'm so happy that you feel that way now. And this is a really good platform to jump off of right now while you've got this motivation going. But do understand that this is a long, long road ahead of you. And, if you've been using for 6 months or 6 years or 16 years, it's not something that just ends because you want to right now. It's going to take a lot of people to help them through that. So with both the adoptive parents and with parenting parents, we need to look at the current and future needs of the child. Obviously, the current needs would be getting them through this NICU stay for neonatal abstinence and helping them to understand how they can best soothe their baby during this time. Our nurses are fabulous about teaching comfort techniques and what works with these babies and what doesn't work with these babies. And they just do a really good job of that. So anybody that interdisciplinary team that I was talking about, anyone who's in contact with the baby and the mom, just provide your support and let them know. Our OT can, when she comes in and she helps positioning with the babies, and then when the parent comes in, she's like, here, try this infant massage. And she does amazing things with an infant massage, and teaching the adoptive parents or the birth parents how to do that gives them a feeling like they are really an active participant in their baby's care, which indeed they are. The lactation nurses who come in and work with the families, their input and support for those moms is also just wonderful. And I see I got ahead of myself. When in the liaisoning with other agencies in adoption, that would be involving the DCS if necessary, the adoption agency, the attorney, and the insurances. All of those are going to be involved. If we have a mom with a managed Medicaid program, when they come in, the baby will get added to that Medicaid. And so part of what we are doing in the NICU is making sure that the NICU stay is covered. And so that would be working with the birth mother's insurance, and then as well as if the adoptive parents have insurance, working with them as well. So making sure that both are getting the information about the NICU stay, and so that everything is covered, because a lot of that too is the fear over these expenses that are upcoming. So coordinating with the outside agencies to attain a safety plan and treatment plan for the family. One obviously is working with DCS, and just keeping contact. I try to call the DCS caseworker at least once a week for my babies who are going through withdrawal, just to say, oh, the baby's still on his peak dose of morphine. He's probably got a few weeks left here. And also when they start waning quickly, when they get down to about 40% of their peak dose, I'll tell DCS, hey, we're down to about 40% now. Start looking for placement within the next week, or finalization of your discharge plan, to make sure that they're kept on top of that, so you don't all of a sudden call one day and say, the baby's been in the NICU for 2 months and now we're ready for discharge tomorrow. So they need to know what's going on so they can make sure and finish their home visits and things like that. If the baby is not going to be going home with the birth parent, then DCS needs to find either relative placement or an appropriate foster home for that baby. So keeping the DCS caseworker up to date on where we're at is very important. Working with the Family and Social Service Administration is also very important. We want to make sure that the baby is continuing to get coverage. So, like I said, if the birth mother has Medicaid, then the baby will get added to that if it's active at the time of delivery. If the mom's Medicaid is only pending, you need to make sure that she is in contact with FSSA office and in getting all of her documentation in so that she is covered, as well as the baby. Also, if the mom has pregnancy-related Medicaid only, I encourage her to go to the FSSA before the end of the following month when her pregnancy Medicaid will end and see if she can switch over to Healthy Indiana plan or some other kind of coverage. If it's a commercial insurance policy, please be sure to let the either adoptive family or the birth family know that they only have 30 days from the day the baby was born to add the baby to the plan. So they should be contacting their insurance customer service or their FSSA office just to make sure that their baby is covered and that they are covered. When I'm talking about getting mom referrals for mental health counseling and addictions treatment, especially if her coverage is due to end soon, we need to make sure that she knows how and who to reach out to make sure that she will continue to get coverage, because if we start that addictions treatment for her, she's willing to go, we need to make sure it's covered. Every mom who is admitted has some kind of a drug of abuse, the cocaine or heroin or benzos or whatever. I will give them a complete list of substance abuse treatment options. They would involve inpatient detox, outpatient detox, inpatient rehab, the intensive outpatient therapy, outpatient counseling, 12-step programs, residential programs, methadone clinics, Suboxone providers, whoever they need. I give them each a list of treatment options for them to go through. Some of them are already involved in treatment, and then that's wonderful. I just say, please just continue with your treatment provider. But if they're going to need something new or something different, or they say this isn't working for them, or yes, I'm finally ready for treatment, please do provide them with resources for that so that they can best try to continue helping themselves and help their babies. Other referrals that we look at for ensuring a safety plan for the baby and the family is also looking at early intervention programs for the baby. Here in Indiana, it's First Steps. And the way we do it is any baby that needs morphine, we will refer for an evaluation through First Steps. And kind of plus or minus on the other ones as to whether if the baby's in just for 5 days due to the methadone exposure but never needs to get on the morphine, we'll just kind of see how the baby's doing. Overall, we take the recommendations of the speech, how they're doing for feeding, and of OT, what's their tone like? Is it real high, real low, real mixed? You know, what does the OT or physical therapist or child life person think? That do they believe that early intervention at this stage is what's needed for the baby? Important of advocacy for the child and the family. That's a huge one, I think, for us social workers is advocacy. Sometimes you agree with the plans in interventions that are recommended, say by DCS, and sometimes you don't. So it's real important to acknowledge your own feelings about it, I guess. And, you know, let's say DCS has recommended that a child be placed back with the family, and they're going to do, say, a safety plan or just an informal adjustment. But in the hospital, nurses or physicians have come to you several times and state, you know, we're really concerned that it looked like this mom was intoxicated last night, or the dad seems high all the time when he's here, or mom and dad are fighting and screaming all the time, or whatever. You can say to the DCS caseworker, hey, maybe let's make sure you're getting some home-based providers in there, or, you know, the nurses were concerned that dad was using or seemed high again, and I know they were clean after delivery, but can you do another drug screen before the baby goes home just to make sure we're sending him home to a clean and healthy environment? On the other hand, sometimes DCS might recommend removal for a family that you feel is doing really well. And I've been called to court on both sides of that fence. I remember a very specific time that I was called to court to testify for the mother, who was actually doing an excellent job with her treatment and had been very, very committed to the baby and bringing in breast milk and, spending many, many hours a day there. She was doing her own counseling. She was going to NA meetings and AA meetings, and she was just really, really committed to doing things right. And baby was there a couple of months. I had a long time to get to know her, and she did a really good job. And DCS, again, advocated for removal from her care, in which case I'm not, trying to second guess their decisions either, but saying, what about considering an in-home CHINS placement for this particular mom, because she is doing so well. That way, if the baby's a ward of the court but able to stay with her, one, they can implement a lot more intensive home-based services for her and make sure that she's doing okay. And you can keep a good eye on her, do your regular drug screens, whatever, but allow her to be with the baby if possible. Especially if she was breastfeeding, which I didn't talk about very much, but so I'm going to just go again off script for a minute, talk about the breastfeeding. So the moms like to breastfeed if they want to breastfeed. If they're very committed to providing that for the babies, that's a wonderful thing. It really is, because especially if they're on methadone, then the baby's getting the methadone through the breast milk, and it's really important that they continue that. However, I always want to add the little caveat that if they are going to do a rapid wean off of their methadone, so is their baby. And so they need to make that an important part of the medical history that they are sharing with the physician and the nurses caring for their baby. The last screen is on facilitating a discharge plan and outpatient follow-up. So a lot of this I've already gone over. So just to recap, before the baby goes home, if DCS is involved, we need to make sure and get authorization from DCS for them to state where the baby is going. Sometimes these babies don't really figure out how to eat well before they leave, and occasionally we'll have to have a baby go home on NG feedings, and so then just coordinating their home care and their DME for the baby. First steps referrals we talked about. Some will prefer to just have the primary care physician follow the baby's development, and if they have any concerns about, again, muscle tone or how they're doing, still continuing to be jittery or something, they may want to make a referral to first steps later. Again, we frequently will do any of our babies going through NAS. They'll get a first steps referral right at the start. I will tell usually those birth parents or adoptive parents too that if First Steps later says the baby doesn't need any services right now, to ask them maybe to come back in 3 to 6 months and just make sure they're staying kind of on top of how the baby's doing and development. We want to make sure that their community referrals are in place, or at least that they've got the contact info. Let's say a mom has expressed some interest in counseling but said they're not really ready yet. Make sure they've got phone numbers, mental health, crisis, addictions, whatever they could do. Having an emergency or a safety plan established is really important. Again, the moms that say, they have stayed clean and they're going back to their methadone clinic or they're going to do a rapid wean off. Again, you want to let them know if they're not going to be using the interventions which have been keeping them clean up till now, like they've been in methadone, able to stay clean, but then they're going to be off. We need to make sure that, you have a nice, honest conversation with them. Say, in the future, should you relapse, please just make sure you are making a safe plan for your child and make sure you take them to a grandparent, a friend that you can trust, somebody to watch over your child so that you're not putting them at additional danger. And honesty is really appreciated by those moms when you have that conversation with them. It's awkward, but go for it because it's really important. And then just making sure that the primary care physician for the baby or their clinic social workers, other outpatient providers, make sure that they received all the information about the baby and what they went through in the newborn ICU. And if you have any questions, you feel free to email me or call me at my number and my email address listed above. Thank you very much.